So today I'll be talking about ankle sprains. That's one of the most common things we see in our clinic. 25,000 ankle sprains a day, and up to 40% of all sports-related injuries are ankle sprains, so it's a very common injury to have. More common, as you might expect, in soccer or American football, basketball, because inversion injuries where the ankle turns in is a pretty common thing, although the ankle can also turn out as well. It's a little more common to see the inversion injury with those types of sports. All ankle sprains don't need surgery, and the majority of them usually can heal on their own. But I wanted to go into the anatomy at first with what an ankle sprain means. I think a lot of people know that they think they know what it means, but we're going to be a little more detailed. The ankle, of course, is made up of bones, ligaments, tendons, muscles, but there are three main ligaments that are associated with the low ankle sprain, which is the most common. There are also three ligaments associated with the high ankle sprain, but I'm focusing more on the low ankle sprain today. The anterior ligament, which is the one in the front, connects the fibula to the talus, so it's called the anterior talofibular ligament. And it is the most common one that is injured. And when we talk about a sprain, we mean that the ligament can tear in one of three ways. Bone is different. Bone breaks or it bruises, and that's it. When a ligament is injured or stretched, a grade 1 is a very mild strain of the fibers that most people probably won't even come to a doctor for. A grade 2 is where part of the fibers will tear, and a grade 3 is where it's a rupture. Grade 2s and 3s both hurt a lot. They swell, and there's usually bruising associated with it because internally the capillaries that go to that ligament tear, and you bleed inside. And so those are two of the more common things that we see in our office. A lot of people think if they can walk on something, then it's not broken, and that's not true, because I have a lot of patients who walk in here on their fractures and won't walk on their grade 3 ankle sprains. And it can take sometimes 2 to 3 weeks before they really want to start putting pressure across their ankle once they've had a grade 3 sprain or a rupture. Usually what we end up doing is we immobilize the ankle with a boot, so that the ligaments can be more reapproximated and heal in a restful environment and more efficient with its healing. Rest, ice, compression, elevation, everyone knows that. But that's really important to do for an ankle injury. The swelling is what slows healing and causes pain, and so all of those things are about decreasing swelling. The rest helps decrease swelling, the ice, the compression, and the elevation. After the boot, we're usually progressing into an ankle brace and starting physical therapy. Somewhere around 3 to 4 weeks usually people can. If it's a severe sprain, they may not be able to start therapy until 6 weeks. If it's not healing and pain continues and it's not progressing like we would expect, usually we're getting an MRI to evaluate it more just so we understand it. But sometimes we have to shift the conversation to talk about surgery and what that would entail. And surgery for an ankle sprain sometimes includes an ankle scope to clean out the ankle joint and the ligament from the inside, but what it usually requires is a repair of the ligaments that are injured that we find out on the MRI. And so, as I had mentioned, the ATFL is usually the most common one that we're always repairing, and that's the one that goes in the front. Sometimes the calcaneofibular ligament, which is the one on the side, it can be injured as well, and the MRI lets us know which ones we need to address surgically, as well as the physical exam. But the name of the surgery, and it's an old classic name, it's called a Brostrum procedure, Brostrum. Some people like to look it up and see videos of it. This is kind of a simplistic model of an ankle, and it shows the anterior talofibular ligament region going from, again, the fibula to the talus. This is an implant that we almost always use nowadays to supplement the primary repair, and I'll show you a little bit more about that. But initially we put an anchor into the bone. There's 2 anchors usually that we use. And from that anchor coming out of the bone is a stitch. And so we sew that ligament back into bone, because remember, a ligament connects bone to bone. And when it tears, we got to bring it back into the bone. And so that primary repair is going to be using the suture anchors. But that tissue is not the best tissue. It's been injured, and sometimes it's been injured repeatedly, because people do this for many years and then they finally decide, I have so much instability, I need to have surgery. And that's more common than somebody doing it acutely after the first 6 weeks. But we often see people who have this routine chronic instability. So their tissue is not good tissue. When a ligament tries to heal itself, it heals with scar tissue. It cannot heal with collagen. That's why sometimes we say it's better to break a bone, sometimes, because a bone heals with bone and you get the same material and it won't bother you. A ligament heals with scar tissue, which is thicker. It doesn't have the same elasticity, and so it just doesn't connect the same way. And so we're repairing your scar tissue back, which is useful. It gives a better tension to that ligament and the hold that it needs to have. But then we want to modify it a little bit more by adding something else. And that something else, and there's a few on the market, and I think they're all probably pretty good. It's a material that if you could feel this, you would feel that it has a little stretch to it. It's not like a rubber band, but when it gets wet, it does have a little more elasticity to it. So it kind of restores a little bit of that natural ligament give. And it's also connected by drilling some anchors into the bone and then tensioning this over the primary repair. So we get a double repair. Most of these tend to dissolve in the body over time, up to 5 years sometimes. But when they've gone back to look at this device, a lot of times they really see collagen. And so it seems to be a better option even than your own body's ability to repair. And they've used stuff like this in the body for sometimes 30 years. So we know that it has a longevity and doesn't usually cause issues. But we do that for most people because we know just one repair like we used to do doesn't work as well, and you're more likely, if you go out and roll it again, you'll tear through our repair. But if we have this double repair, you're more likely to have just not those issues with a repeat injury. So, of course, please come see us if you have continued pain after an ankle injury, let's say more than, a week. Certainly happy to see you sooner if there's concerns. Sometimes it's so severe you want to be seen within a day or two, and we usually can accommodate that well. And don't worry, not everybody needs surgery. We're just here to help you, whether it's conservative or surgical.